Thank you, all of you. Good morning. Yeah, you're most welcome to this series of CME at Gulu Regional Referral Hospital. I would like to start by thanking our head of the department of obstetrics and gynecology of the department, Dr. Baifa, who is here with us. Thank you for coming. I thank the head of the nursing and midwifery team of the maternity for organizing this CME. Thank you so much. And I would like to welcome all of you for this session. It's going to be more practical because we want to have this learning session a little bit more practical. The purpose for us today is to learn and we go and apply the principles that we have learned. You realize that we are going to be bringing to you new things that have been recently revised. Dr. Baifa will remember when they went to for the revision of the new guidelines. So most of those things will be even in the extract from the guidelines that has been recently published last year in 2021 October. So this is a new guidelines that we will be publishing to you today so that you people can be able to learn and we start applying them. Yes, antepartum haemorrhage is the topic for today's discussion. My name is Dr. Jimmy. I am an obstetrician and gynecologist lecturing at Gulu University, Faculty of Medicine, Department of Reproductive Health. Today, we're going to look at this antepartum haemorrhage, this monster called antepartum haemorrhage. I'm happy to declare that this session has been facilitated by Gulu Referral Hospital, the Faculty of Medicine of Gulu University, and then I was provided by some facilitation from the administration of Jowa Medical Center and Maternity Home here in Gulu City. Basic outline for today, we're going to look at one case scenario, just to help us get into this monster of antepartum haemorrhage. Then we are going to finally define what antepartum hemorrhage is, and then we are going to look at the clinical features of antepartum hemorrhage. Now, these clinical features will tailor it to the different causes, because the general clinical features may not give us a very good picture of what different causes could be. Then we're going to look at the differential diagnosis. It is important to know, if it is not antepartum hemorrhage, what else could be there in the patient? And then finally, the common causes with their management. Last thing that we are going to look at is preparedness for the complications and some precautions that we need to follow. And this forms the basis of our talk today. Now, on the picture that you can see there is just an illustration to show you that this monster called antepartum hemorrhage, you can have the bleeding that can be seen, and sometimes the bleeding may not come out, but the hemorrhage is occurring. So that's the typical picture that I have there for where the baby is bleeding internally, the bleeding is internal, then the bleeding is revealed. That's just a simple illustration for you. Now, let's look at a simple case scenario here for us to get into the gist of this antepartum hemorrhage. We have a 28-year-old gravida 6 × 5+0, at 30 weeks of gestation. She was admitted in maternity unit with sudden onset of vaginal bleeding for 2 hours after road traffic accident. She fell off a border that was carrying her to come to the hospital for just the antenatal care. Now she has reported constant abdominal pain, and when we examined, we found a tender uterus, and however the fetal heart was still regular at 148 beats per minute. When we examined the vulva and vagina, it was grossly soiled with blood. So what do you think is the problem here? What do you think is the diagnosis here? It looks a little bit very, very straightforward, not so? Yes. Yes. And this is what we actually experience all the time. When you have such kind of patient, I'm talking about a scenario which happened here, not that it's something that is framed, okay? So this is a grand multigravid woman, 28 years old, and she reported with this kind of complaint. It is important to appreciate that this is a typical case of antepartum hemorrhage. Now, what is this antepartum hemorrhage that we talk about? World Health Organization adopted a definition which defined it as bleeding from or into the birth canal, which occurs after 20 weeks of gestation, or when the fetus is about 500 grams, and this occurs before delivery. Different countries tend to define antepartum hemorrhage differently. And that's why it is important for us to appreciate that we are adopting, as Uganda, we are adopting a new definition, okay? Because we lowered our weeks of viability for our fetus to 26 weeks of gestation. So now that modifies our definition for our country, Uganda. In other countries like Egypt, they may define it at the cutoff weeks of gestation is 24. In the US and developed countries, 20 weeks of gestation, because that's their weeks of viability for their fetus if they're born. So for Uganda, any bleeding from or into the birth canal, which occurs at or after 26 weeks of gestation, or when the fetus weighs about 800 grams, and this occurs before birth of the baby. Now, the word before birth of the baby, it means when the second stage has ended, that's where that definition stops, okay? At the end of the second stage, when the second stage has ended, now what occurs, if bleeding continues to occur, that will bring what we call postpartum hemorrhage. And that's the revised Ministry of Health Essential Maternal and Newborn Care Guidelines that has been published last year, 2021. So I think you'll take note of that. It's very key. We used to teach medical students, we used to talk to colleagues about 28 weeks of gestation. Now we lowered it by 2 weeks, okay? What are the approaches that we have for antepartum hemorrhage? The approaches are many, but more importantly, history taking at all times is the first thing. Then physical examination and systemic examination follows. You must do this in your clinical practice all the time. That's why you see people take their time taking history. It is very important. Before you ask for some investigation to confirm some of the diagnoses that you think could be causing the problem. However, this antepartum hemorrhage is common. About 4 to 5% of all pregnancies get complicated because of antepartum hemorrhage. So it is very common. You take 100 patients, 100 mothers who are pregnant, 4 of them normally get complication from this antepartum hemorrhage. So after knowing that, how do you elicit the causes? The causes are many, but common causes normally occur commonly. And that's what we normally always emphasize. Abruptio placentae or abruptio placenta. 30% of the time, abruptio placenta is the cause of antepartum hemorrhage. Other causes are placenta previa, which contributes to about 20% of the time, causing antepartum hemorrhage. Other causes tend to be rare, but they can also occur. And that's why it is important for you to also remember and know. One of them is ruptured uterus. It's a little bit becoming common. Vasa previa, not very common, it's rare. Other causes include genital tract infection, for example, cervicitis. We also have tumors of the vulva, vagina, and the cervix. And I want to make it clear that it has been noted in many studies that even choriocarcinoma can occur, although it is rare. Other causes could be polyps and cervical lesions or erosion. Now, the 2 common causes that I've mentioned above, abruptio placenta, abruptio placentae, and placenta previa. These are the 2 common causes. And so at all time, when you're thinking, when you get a patient presented with late pregnancy bleeding in the 2nd trimester or 3rd trimesters before delivery, that is from 26 weeks onwards, in our setting of Uganda, think about placenta abruptio or abruptio placentae and placenta previa. Okay? At all time, please think about that. So our focus will also tell us to what is common, what causes it commonly, and so we need to exhaust it a little bit further. Looking at the clinical differences that may appear in patients with placenta abruptio and placenta previa. So these are the common ones. But what I want to summarize for you here, not to take a lot of time as well, is that 2 things in history. Ask for bleeding and the nature of that bleeding. Yes, ask for bleeding. I know all of them ask. We always tell you that they are bleeding. They come to the hospital because they are bleeding. But please, the nature of bleeding matters a lot. In abruptio placenta, normally these women passes dark blood, which may not be clotted, sometimes may be clotted when the bleeding has been there for some time. And there may be bleeding that may be seen externally or may not be seen. I have projected for you the initial picture that illustrates that it can be concealed or it can be revealed. Meanwhile, on the other side, for placenta previa, there may be just kind of warning bleeding or just bright red bleeding gets collected. This blood gets collected within the vagina. It can actually form the clots. Sometimes you can even be able to see the clots. The other thing is ask about abdominal pain, and the nature matters. With abruptio placentae or placenta, there are always constant pain that you get. Meanwhile, placenta previa is typical. Normally, there is no pain. So the bleeding is painless in most cases. It is important to examine, and that's why I brought these two aspects: abdominal palpation, findings, and then auscultation. Now, especially abdominal findings, you have woody heart and tender uterus, and that's what our patient in the case scenario presented with. Meanwhile, in most cases, placenta previa, there is no tenderness of the uterus. Fetal heart auscultation, normally it is variable depending on the degree of the bleeding. However, we can have a lot of issues when you have placenta abruptio or abruptio placentae. You have bradycardia or tachycardia, and even sometimes you have these fetus may not be living, may be dead already. So you have absent fetal heart. It can also occur with placenta previa, though the degree is what matters, what defines the changes in the fetal heart rate. Yes. Let's look at the differential diagnosis of a patient with antepartum hemorrhage. One of the commonest is abruptio placenta. I told you at the beginning that they constitute about 30% of all cases of antepartum hemorrhage, and it's very common. The other one is placenta previa, about 20% of most of the cases of antepartum hemorrhage. And then we have other causes like rupture uterus, also becoming very common. We also have vasa previa, also common. It is important to know that if this bleeding is concealed sometime, we need to think about the degenerative changes that occur, what we call degenerative fibroids, twisted ovarian cyst, or even acute appendicitis. For twisted ovarian cysts are those on which are hemorrhagic, they can bleed, and then you have intraperitoneal bleeding, and you have to get these similar symptoms of patient having like antepartum hemorrhage. Now, how do we investigate patient? Generally speaking, patient with antepartum hemorrhage, you need to do a lot of investigation, which include knowing the hemoglobin. This gives us a baseline. However, if a patient is bleeding profusely, acute bleeding, normally the hemoglobin may not change within a short time, unless you have lost too much blood. However, this helps in the baseline hemoglobin, knowing what hemoglobin baseline is. Then, in some facilities, you don't have the way of estimating hemoglobin. What you do complete blood count. We will still give you hemoglobin level. We need to do platelet count. It's important that most of this plasma, normally when the patient is bleeding, they come out with the platelets. So these platelets that are suspended within the plasma, they are normally consumed by bleeding, and so you can have coagulation disorder, what we call consumptive coagulation disorders due to antepartum hemorrhage. The other thing is that we need to do is blood grouping and cross-matching, which is important because we need at all time to get blood, a lot of blood for this patient. And this patient most of the time requires blood transfusion if they have sufficiently lost a lot of blood. Ultrasound scan is to help us confirm our diagnosis, which is unquestionable and should normally be on our bedside. The other tests that are also important are clotting time, also bedside thromboplastin time, activated partial thromboplastin time. The analysis is important in fact, by the time most of this patient comes in, they have lost a lot of blood, and so they are hypotensive. But still, it's important to rule out features of preeclampsia, eclampsia by doing the analysis, because patients with preeclampsia, eclampsia are at risk of developing antepartum hemorrhage, mainly because of developing abruptio placenta. Management of antepartum hemorrhage is very, very important. It is a teamwork, and so at all time, you call for help, you gather the team to manage antepartum hemorrhage. All mothers with antepartum hemorrhage should be managed in a hospital that can be able to perform cesarean section, cesarean hysterectomy, and blood transfusion. And those facilities should have the 9 signal functions, including those 2 that I mentioned, and so they are called Comprehensive Emergency Obstetric and Newborn Care Facility, the CMOC facility. If you are not in the CMOC facility, therefore you could be in a basic emergency obstetric and newborn care facility, Health Center 3 and below. You make sure you refer this patient to the CMOC facility. Ensure that there is a pre-referral care that you have given. Do not perform dictobogenic examination, but you can actually inspect the vulva to see blood clots and see what is there. Establish 2 large bore cannulas for patients who are bleeding profusely, and make sure you give this patient Ringer's lactate or normal saline, preferably normal saline, which is available in our setting. What I've added, which is of importance, is that make sure that you give these mothers anti-D immune globulin if the mother is rhesus what? Negative, while the husband is rhesus positive, because there's a possibility of having the baby with rhesus positive, and so we don't have that alloimmunization to occur. The other thing is sometimes this patient may require cesarean delivery in case they're actively bleeding or they're unstable. So it is advisable that the team provide general anesthesia instead of preferring to give spinal anesthesia. So general anesthesia is preferred for unstable mothers or those who are actively bleeding, so they may not withstand the spinal anesthesia. Now, management of antepartum hemorrhage now depends on the cause. We also consider gestational age, we also consider maternal and fetal condition, and even the severity of bleeding. And this will now usher us to what precautions should we take in an attempt to mitigate this antepartum hemorrhage. The 4 don'ts and some of what we call the 4 things that you should consider when you want to deliver. One of them, the 4 don'ts, one of them is dictobogenic examination should not be encouraged until you have ruled out placenta previa. Bladder catheterization may lead to injury of the bladder. So sometimes it is difficult to categorize these women. And then also rectal examination is discouraged and rectal enema is discouraged. When to deliver? If the fetus is at term, deliver. If the fetus is dead, please optimize and deliver. Unstable mothers must be delivered, and also mothers in labor, ensure that you plan and they get delivered.